Tan from Singapore, Tan Tock Seng Hospital. He's currently the head of the department, and his major interest is in endovascular aortic aneurysm repair, and also open and endovascular surgery for lower limb salvage in peripheral vascular disease. Today, his topic is applying fenestration to TIVA in ARCH, application, outcome, and future direction.
Thanks for the kind invitation. Thanks for the kind introduction. I'd like to thank Professor Vera Wong for the invitation to Aortic Asia as well to attend this conference. And this is where I work. It's a 1,800-bedded hospital in central Singapore with a full complement of surgical services. I have no conflict of interest to declare. So, is there a truly durable endovascular option for arch aneurysms? We know that the hybrid options have served us very well, but these come with a staged procedure, a stroke risk, as well as a necessity for prosthetic graft, and these carry a risk of infection as well. This patient of mine came back 6 months later saying, "Doctor, I still feel a necklace in my neck. What do you do to me?" So some of these patients are not satisfied with a hybrid procedure sometimes. We can do a total endovascular procedure with a chimney technique, but we know there's up to 10% risk of type 1 endo leaks. And so we explored doing fenestrated thoracic EVA around 3 years ago in our hospital. We all can agree from the earlier talks that these cases are not suitable for endovascular repair. They all require some form of ascending repair. So for what we use in Tan Tock Seng Hospital is the Cook Medical fenestrated device. It can come in many configurations, either a single scallop, a scallop with a fenestration, or 2 fenestrations sometimes. And these can be customized according to the needs of the patient. We've done up to 2 fenestrations and 1 scallop as well. No discussion about fenestrated TIVA is complete without talking about the Najuta stent graft. This is only done in Japan with many studies and large series as well with very good results. Unfortunately, this is not available commercially in the rest of Asia and Singapore, but they have excellent results from what they've done so far, with a very low mortality rate and almost a negligible stroke rate. And there's also the Bolton stent graft, which some of the speakers mentioned earlier. This one it can be customized with fenestrations as well as scallops. There's also not much data on this. What we use is this Cook fenestrated stent graft. It always comes with a preloaded catheter. It aids in the cannulation of the target vessel and it helps with the alignment of the graft. I usually preload the catheter in the most important target vessel. So if I do a 2-vessel fenestrated TIVA, I will preload it in the left common carotid artery. And this will help you to align the graft up to the target vessel. This is the plan, and usually I would now customize 8mm fenestrations. When I first started doing them, we were doing 10mm fenestrations. Part of the reason for using smaller fenestrations is because we can use a B graft 8mm, which goes in a 6 French sheath, and we can do it percutaneously from the carotid and from the brachial artery as well. And this device comes on a pre-curved delivery system with a short nose cone as well, so there's less damage to the aortic valve in the left ventricle. We usually snare the wire from the target vessel, either left common carotid or the left brachial. We use a gooseneck snare because it's 6 French rather than a Indy snare, which is much bigger. And once we get the wire in the target vessel, we tighten the through and through wire, and we pull the device up into the arch, and we start deploying it under tension. If you don't have enough tension on the through and through wire, you might sometimes end up with a wire wrap like this. The wire wraps around the front of the stent. This becomes a situation where it's almost unsalvageable, and you will have to pull out the wire from the catheter, and you need to directly cannulate the fenestration. We've had this problem in the first few patients that we did, but we're very lucky to be able to salvage these patients. And once we get a Rosen wire into the fenestration, we exchange this for a balloon, and we inflate the balloon while we deploy the rest of the graft. By inflating the balloon, the fenestrations, we align the fenestrations to the target vessel, and then it fixes the graft while we deploy the graft fully, so that the fenestrations will line up with the target vessels. You can see it over here. And so we wrote